Hi friends, I am Dr. V.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and as a reference to medicals. Today I am going to discuss about the process of labor, that's delivery. The process of delivery is divided into 3 stages and is accompanied by preparatory stage, which may begin about 3 weeks before the onset of the labor in primigravida and a few days before in multigravida. The phenomenon of preparatory stage consists of falling forward of the uterus with the head sinking into the pelvis, resulting in lightening due to the relief of pressure exerted by the gravid uterus on the diaphragm and therefore on the lungs and heart. The gradual shortening of the cervical canal, a process that commences some days before the actual onset of labor in some cases. Falls or spurious labor pains which occur frequently in primigravida than in multipara. Falls pains are more often caused by a temporary indigestion or by a loaded rectum. They are relieved either by a laxative or enema. They are differentiated from labor pains by the temporary nature, irregular, and by the fact that they are left over the abdomen instead of lumbosacral region or above the pubis. They do not progress, not associated with any contractions of the uterus, and do not cause dilatation of cervix. When true labor pains are set in, 3 stages are described. They are first stage or stage of dilatation, second stage or stage of expulsion, third stage or stage of placental delivery and uterine contraction and retraction. First stage. This extends from the onset of the true labor pains to the complete dilatation of the cervix when the rupture of the membranes usually occurs. The duration of this stage is variable, extends in primigravida to 16 hours and in multigravida 6 to 8 hours. Phenomena during this stage of labor are uterine contractions or true labor, mucosanguineous discharge or the show, dilatation of the cervical canal so that both the internal and external orifices become completely dilated. In normal cases, fixation of the head of the brim of the pelvis and its progressive descent. And lastly, rupture of the membranes. Uterine contraction occurs at the intervals of half an hour at the starting of first stage. Gradually, they become more frequently till towards the end of the first stage. They may occur very few minutes. The duration of each contraction lasts nearly 45 seconds. Each contraction gradually increases in intensity, reaching an acme and then diminishes in intensity. In normal labor, the intrauterine pressure is usually about 35 mm of mercury. Sometimes it may be as high as 50 mm of mercury. First, the pains are felt at the sacrum and later they radiate to the lower abdomen and sometimes down the legs. Sometimes may be associated with a feeling of nausea and vomiting. There may be frequency of urination. The cervix becomes more soft and patulous. Till the end of this stage at full dilatation, its diameter is about 10 centimeters. Mucosanguineous discharge. Just before the beginning of labor, a small amount of red tinged mucus may be passed, that is show. This is a plug of cervical mucus mixed with blood and is evidence of cervical dilatation and effacement and frequently descent of the presenting part. Dilatation of the cervix. This is due to the contraction and retraction of upper segment, lifting up the thinning out the lower segment, ultimately pulling the cervix over the advancing presenting part without significantly altering the level of the external os in the pelvis. A well-fitting presenting part favors good uterine action and smooth dilatation of cervix. The bag of four waters is not essential to the process of dilatation of the cervix. After the rupture of the membranes, the pressure exerted by the presenting part on the cervix induces reflex uterine contractions, which are more powerful than the one before rupture. These further aid in more rapid dilatation. The upper part of the cervix is muscular, while the lower half, especially the external os, is fibrous in character. Dilatation of the external os therefore depends not only on the strong coordinate action of the muscles but on its own capacity to soften and stretch. This in turn depends in its intrinsic development and on its preparation during pregnancy. The hormones estrogen and the progesterone play a part in this preparation. Lower uterine segment. During labor, under the influence of uterine contractions, the uterus gradually becomes differentiated into a distinct portions. The upper segment is thicker and more active and becomes thicker as labor advances. The lower portion, that is lower segment with the cervix, is passive and becomes thinner and stretched out to receive the descending fetus as the labor advances. The junction of upper and lower segment is characterized by a ring of circular muscle fibers called a physiological retracting ring. Above this is the contracting thick upper segment and below the dilating and stretching lower segment and cervix. This ring becomes prominent in obstructed labor when it is termed the pathological retraction ring or BANDL'S ring. The lower uterine segment is developed from the isthmus of the uterus, which is defined as that portion of the pregnant uterus situated between the anatomical internal os and the histological internal os, the former being higher. This area will grow as well as stretch during pregnancy. Some believe that the lower part of the corpus uteri has also a share in the development of the lower uterine segment in pregnancy. The lower uterine segment is formed by the retraction of the upper segment, which pulls up the thin out the tissue intervening between itself and the fixed cervix. The thinning that occurs in labor of the lower segment is due to the downward and outward thrust of the descending fetus. The upper margin of the lower segment is about the level of the upper border of symphysis pubis in late pregnancy and is indicated by the line of close attachment of uterovesical fold of peritoneum. The process of cervical dilatation differs in a primigravida from a multipara. In primigravida, at the commencement of labor, whole of the cervical canal is closed, both the internal and external os are occluded. The dilatation occurs progressively from above downwards, the internal os dilating first and the cervical canal and lastly the external os. In multipara, the external os is patulous, usually admitting freely one finger, one or sometimes more. The internal os is not completely occluded. The process of dilatation is therefore a little more rapid and easy. In majority of cases, the head becomes fixed at this stage if it has not done so in last 2 or 3 weeks of pregnancy. Non-fixation of head in cephalic presentation suggests the possibility of Abnormalities. The membranes usually rupture after full dilatation of the cervix when the second stage commences. Second stage. The second stage of stage of expulsion extends from the complete dilatation and rupture of the membrane to the expulsion of the fetus or fetuses. This stage may last for 1 or 2 hours in primigravida and from half an hour to 1 hour in multipara. The nature of the uterine contractions gradually changes, getting stronger in the second stage. They are more severe than in the first stage and are of a bearing down character. The voluntary muscles and accessory muscles labor also begin to contract and exert their influence towards the end of the second stage. The diaphragm and abdominal muscles begin to act, and the patient clutches at anything she can get hold of. With each of these pains, the fetus is driven down through the dilated cervical canal, and vagina reflexes and dilates to receive the presenting part. When the perineum is reached, it's stretched so that it bulges with every uterine contraction. The vulva begins to agape when the presenting part is fixed under the symphysis pubis, the process known as crowning of the head in vertex presentation. At this stage, the patient feels as inclination to micturate and defecate due to pressure of presenting part on the bladder and rectum. Lastly, the head passes through the outlet with a series of almost continuous uterine contractions, helped by involuntary stretching efforts on the part of the patient due to the action of accessory muscles of labor. As expulsion of the presenting part takes place on the patient utters a sharp cry or groan, and thereafter the rest of the fetus is born. Third stage of labor. The third stage of labor or stage of placental delivery is very important and should be carefully watched. This extends from the complete expulsion of the fetus to the complete expulsion of the placenta and membrane, and from contraction and retraction of the uterus subsequently. The average duration of this stage, when spontaneously completed, may extend up to 15 minutes. As soon as the birth of the fetus is over, the woman feels relief and is calm and comfortable. There may be a feeling of faintness caused by sudden evacuation of the uterus, usually after the delivery of the large-sized fetus, or when the uterine contents have been suddenly evacuated, as in case of hydramnios or twins. The phenomena of third stage of labor or characteristic uterine contraction, separation of placenta, expulsion of placenta, control of hemorrhage, permanent contractions and retractions of the uterus. Uterine contraction. After completion of the second stage, the uterus will pound almost at the level of the umbilicus and is firm, round and hard. Rhythmic contractions will occur and the patient may sometimes feel the pains. Placental detachment. As the fetus is delivered, separation of placenta takes place. The shrinkage of the placental site and forcing downward of whole placental mass by uterine contractions may cause separation. Placental expulsion may be either of two methods. Due to contractions of the uterus, the placenta may be folded on itself so that the long axis of the placenta corresponds to the long axis of the uterus, and the margin that persists at the cervix of the vagina is the lower margin, showing perhaps a little of fetal surface. The second method is the placenta may separate at its center. A retroplacental hematoma is formed, which with each contraction of the uterus forces more of the placenta to separate, and the placenta thus separated presents itself at the vaginal outlet. With the center of its fetal surface with its attachment of attached cord like an inverted umbrella. Of course, both methods are of same importance. Expulsion of the placenta occurs within few minutes after the birth of the fetus. During this period, the uterus is moderately hard as the result of tonicity, so that when the placenta separates, the contractions and the retractions of the uterus will arrest hemorrhage may closure of the placental sinuses. The control of hemorrhage after separation of the placenta is due to three factors. Contraction and retraction of the uterus, contracting the vessels passing through the uterine wall to the placental site. The occlusion of the torn vessels themselves. The formation of blood clots which favor the closure of the lumen of the vessels. During the third stage and immediately after, there is always a moderate amount of bleeding. In a normal case, it does not exceed 250 ml. When the labor is over, the patient may occasionally have a rigor, which is purely a vasomotor phenomena and is not indicative of infection and is generally of no particular significance. It is called the physiological chill. That's all about the process of labor, and in the next video I will discuss about some other disease. Thank you.